This is a video of a 46-year-old carpenter. He gave history of injury which was treated medically with recurrent episodes of pain and redness. At presentation, his best corrected visual acuity was perception of light with inaccurate projection of rays. Examination showed signs of healed uveitis with 360-degree posterior synecdoche and complicated cataract obscuring the fundus view. B-scan revealed inferior retinal detachment and vitreous echoes on higher gain. There was no evidence of foreign body on CT scan. Our diagnosis was complicated cataract with vitreous opacities with partial retinal detachment. Cause was a dilemma, whether it was due to chronic uveitis or chronic traumatic endophthalmitis or an old RD with uveitis and complicated cataract. Patient was posted for cataract extraction with complete vitrectomy. Under local anesthesia, anterior chamber entry was done with 2.8 mm keratome. Anterior chamber deepened with viscoelastic. Synecholysis being done with the help of iris repositor. Further dilatation of the pupil was done using iris hooks. Capsulotomy done with needle cystitome. After hydrodissection, phacoemulsification was done. Gauge infusion cannulas were placed, and in view of fibrotic posterior capsular plaque, primary posterior capsulotomy was done. Vitreous biopsy was taken. PVD was induced and rest of the vitrectomy was completed. After staining with the brilliant blue dye, ERM-ILM complex was peeled off from the macular region. Perfluorocarbon liquid was put to stabilize the posterior pole detached retina. During peripheral vitrectomy and base excision, a retinal fold in the nasal periphery with a fibrotic tissue in the extreme periphery was noted around 1 o'clock meridian. The fibrotic tissue was dissected with the help of a vitreous cutter. To our surprise, after tissue dissection, we could see the release of wooden foreign body, which was neither suspected clinically nor was picked up pre-operatively. Foreign body was picked up with vitreous forceps and under viscoelastic delivered through the existing phaco wound. Further dissection of residual fibrous tissue was done to look for the remnant of foreign body and also to relieve the traction on radial retinal fold. After relieving all the traction, fluid air exchange was done. Endolaser was done to all the breaks. Tamponading was done with the help of silicone oil. At 3 months post-op, his anterior segment was quiet with best corrected visual acuity of 6 by 36 with aphakic glasses. Retina was attached under oil. So what we learn from this case? Small wooden foreign bodies cannot be picked up by ancillary investigations, especially when they are in vicinity of the codes. Always suspect retained intraocular foreign body with history of insignificant trauma in cases of chronic uveitis. While doing vitrectomy, if you encounter fibrotic tissue, do explore it. It might have retained intraocular foreign body. Thank you.